Good afternoon. Okay. So welcome to everybody. Final instruction, please mute yourself, but always show your video picture. Sign in your name, FB account, email address in the chat box. Include the names of your companions. Use the chat box to ask questions and make comments while the pep talk is on. So there'll be group pictures at the start and end of the pep talk. So show your face in the video. As a reminder, take the online Learning Cum Evaluation Test exercise or OLETE for mastery of learning and have a perfect score to get a certificate of commitment and accomplishment. Okay. I have placed the link in the chat box. Okay. So welcome all again. Let's now have a group picture taking before we start in 1 or 2 minutes. Please turn on your video now. Gallery. Okay. Can you also take pictures on your end? 1, 2, 3. First picture. There are 2 pages here. Let me save it first. Page 2. Okay, show your face. 1, 2, 3. 1, 2, 3. Okay. So let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. I launched this pep talk on May 15, 2021 with the first module on COVID-19. The second module was on patient empowerment. This is the third module, patient management process. What I have in mind in my pep talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. That is my key performance indicator. I hope you will be in this group of 30. This is the patient management process framework, which I discussed, which I gave an overview last time. The module on the patient management process has 6 parts: overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process, and peculiarities and limitations of medical practice. So for today, we will be on the clinical diagnostic process. So I will be focusing today on this part of the patient management process, the goals, and the clinical diagnostic process. I have this empowerment objective for the lay people to have an understanding of the goals and the clinical diagnostic process in the patient management process. The patient management process starts with a patient consulting a physician for a health concern. There are 2 categories of reasons for medical consultation. One is consulting for management of a symptom or a set of symptoms. The other is consulting for screening for a disease or diseases. Although the PNP is applicable to both categories of medical consultation, for today I will focus on the management of a patient with a health problem so that I can easily give scenarios or examples for illustrative purpose. A patient consults a physician. The goals of the physician are resolution of the health problem in such a way that the patient does not end up dead, as much as possible with no complications and no disability, in such a manner that the patient is satisfied. These are the universal goals of all physicians. These are also rightfully the expectations of the patients. There are caveats in these goal statements. Medicine is an inexact science with nothing absolute, nothing guaranteed, with no perfect achievement of goals at all times. Despite these harsh realities, an idealistic goal should still be set to guide the physician, their fighting target. What is most important is that physicians exert their best, rational, honest, and humane or compassionate efforts in managing patients to the satisfaction or delight of the patients and relatives, even in the absence of complete resolution of the health problem. As mentioned earlier, these goals of the physician are rightfully the expectations of the patients, but the latter, meaning the patient, should understand the limitations of medicine and also their physicians when the goals are not completely achieved. They should appreciate the physicians as long as the physicians exert best, rational, honest, and humane or compassionate efforts in caring for them. To achieve the goals, a physician performs 4 basic categories of functions or tasks. These are rapport, diagnosis advice, treatment advice, and then advice. The general quality standards that can be used for these 4 tasks are rational, effective, efficient, and humane. After establishing rapport with the patient, the physician starts accomplishing the task of diagnosis. Diagnosis means coming out with statement of what a patient has at the current moment after evaluating the symptoms and signs. If the patient comes in with reports from laboratory examinations and procedures done prior to the consult, they are included in the evaluation. Before coming out with a diagnosis, the physician interviews and does physical examination on the patient. The data gotten from the interview are called symptoms. So symptoms is defined as what the patient feels and observes in his body, which can be a manifestation of a medical condition or a disease. The data gotten from the physical examination are called signs, which is defined as findings obtained by a physician after doing a physical examination. A diagnosis just derived from symptoms and sign is called a clinical diagnosis. In some instances, as mentioned, a patient consults a physician bringing along reports of diagnostic procedures done earlier. In such instances, the physician will incorporate the data from the diagnostic reports in the clinical diagnosis. In processing the symptom and sign data and other data for that matter, the physician uses the clinical diagnostic processes called pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. So pattern recognition is essentially the same as a matching process. Prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. Illustration 1 for the clinical diagnostic process. Knowing the common manifestations of 5 different diseases as follows. Disease A, ABCD manifestations, B, FGHI, C, KLMN, D, PQRS, D, this is E, UVWX. Given the patient manifesting with PQRS, your diagnosis should be disease D, as in dog. So what is the process used? Pattern recognition. Illustration number 2, knowing the common manifestations of 3 different diseases and the relative frequency of each as follows. This is A, ABCD manifestation, but the least common. And this is B, the same manifestation, frequency in between these two. This is C, ABCD manifestation, but the most common. Given a patient manifesting with ABCD, your diagnosis is disease C. So what is or are the processes used? Pattern recognition, because you recognize a pattern of ABCD, but you choose D as C because it's the most common. So mainly prevalence. Illustration number 3, knowing the most common diagnosis of a thyroid nodule is benign colloid adenomatous goiter. This is without examinations, without physical examinations, okay, without including the symptoms. Given a patient with a thyroid nodule, you gave the above mentioned diagnosis. So what is or are the processes used? Prevalence. Patients presenting with these pictures of mouth defects, who has cleft lip for a diagnosis, and who has a cleft lip and palate, and what is the process used? The one on the left side of the screen has cleft lip because only the lip is involved. The one on the right side has cleft lip and palate because the palate is also affected. The process used here is pattern recognition. The patient has bulging eyes and enlarged thyroid. What is the diagnosis and what process is used? Bulging eyes and an enlarged thyroid gland are the usual presenting signs of hyperthyroidism. So here we recognize a pattern of hyperthyroidism. Thus, the diagnosis is hyperthyroidism, and the process used is pattern recognition. A patient has cough, colds, fever, and tiredness. COVID-19, flu, and common colds present with the same set of symptoms. How does one process for a diagnosis? COVID-19 should be the primary diagnosis during time of COVID-19 pandemic. The process used is prevalence. During the time of flu pandemic, epidemic, or outbreak, when COVID-19 and common colds are not common, then flu should be the primary diagnosis. The process used is prevalence. At this point, I'd like to insert something still related to our discussion on the clinical diagnostic process, but which I advise you to remember for the rest of your life and be empowered by knowing, for chances are you will be confronted with it, and now in the future, and on yourself and on your loved ones. This is how to diagnose a mass on the body surface using pattern recognition. Foremost question to ask is whether the body surface mass is cancer or not cancer. Using pattern recognition, know and look for signs of cancer and also signs of not cancer. If signs of cancer are present, the primary diagnosis is cancer. If no cancer signs are present, so more likely not cancer, especially if there are signs of not cancer. Signs of cancer that can be used for pattern recognition are the following: hard, solid mass, fixed mass with skin changes overlying the mass, lymph nodes on the same side of the mass, distant mass suggestive of a spread. Signs of NAT cancer that can be used for pattern recognition are cystic mass, which means it most likely contains fluid, and signs of inflammation, infection such as pus, redness, tenderness, etc. The output of the clinical diagnostic process is diagnosis. And as mentioned, diagnosis is an identification label of the patient's health problem. The elemental steps in making a diagnosis or a diagnostic statement consist of the following. First, identify which organ or tissue or system is involved. Then identify the disease in general terms, such as inflammation, infection, tumor, trauma, endocrine disorder, etc. Then try to be more specific in identifying the disease, if possible, such as malignant neoplasm or cancer, abscess, etc. Examples of diagnostic statements: right breast mass, malignant. Okay, so right breast represent the organ or tissue. Mass represent the disease in general. Okay, and malignancy is the specific disease. Okay. Knowing the nomenclature of the diseases facilitates diagnostic labeling. Note, however, the diagnostic labeling does not always have to contain the name of a disease. The patient may not have a disease after all, or may just have a medical condition that is not equivalent to a disease. In such situations, the diagnosis may contain a statement like essentially normal findings, normal anatomical variations, a medical condition such as pain, okay, headache, fever that will most likely resolve spontaneously in time, etc. Since medicine is an inexact science with nothing absolute, there is usually no such thing as one absolutely certain diagnosis after an evaluation. There is usually an alternate diagnosis. Thus, in the end, the outputs of the clinical diagnostic processes are at least two diagnoses. Primary clinical diagnosis, which is the most probable and most likely, and the secondary clinical diagnosis, which is the alternate, second most probable, or less likely diagnosis. With the harsh reality and limitations of medicine, a diagnosis is almost always an educated guess. Note the adjective for the guess, educated. It has to be educated to be acceptable in the medical profession and to the lay people and patients as well. And to come out with an educated guess, a process or processes should be used. The clinical diagnostic processes must be rational for the clinical diagnosis to be acceptable. There is an adage that states, a diagnosis that is based on a rational process is not always correct. However, a diagnosis is more often correct than wrong if it is rationally arrived at. Going back to the primary and secondary clinical diagnosis, the physician must quantitate his degree of uncertainty or certainty, as this will serve as a guide in deciding whether a paraclinical diagnostic procedure will be needed or not. As a rule, if the primary clinical diagnosis is already certain, no need. If it is not certain, there is a need for a paraclinical diagnostic procedure. How to quantitate? At the moment, there is no universal agreement on this. I will just share with you my practice, which I find practical in determination of the degree of uncertainty or certainty and in explaining to patients. Use two dichotomous terms, certain and not certain, but at times you can use four terms, very certain, not certain, certain, very certain. This is for the patient, for the sake of the patient's better understanding. Use a subjective probability percentage for the cutoff in the dichotomy, 90%. So certain, for 90% probability and above, not certain for less than 90% probability. The subjective probability percentages can be given as 60-40, 70-30, 80-20, 90-10, 95-5, 98-2, 99-1. The first percentage is for the primary clinical diagnosis, and the second percentage is for the secondary clinical diagnosis. Thus, the range of uncertainty is 60% to below 90%, and the range for certainty is 90% to 99%. Examples: 99 to 1% means 99% probability for the primary and 1% for the secondary clinical diagnosis. 60-40 means 60% probability for the primary and 40% for the secondary clinical diagnosis. Now, if there are published in the literature the frequential probability statistics, there are studies made on this, then use them but place them in either of the two categories of certain and not certain. The use of the relative strength of the symptoms and signs and the processes used. So the general rules are: a clinical diagnosis is considered to be certain if it is based primarily on signs supported by symptoms and prevalence data. A clinical diagnosis is considered to be uncertain if it is based primarily on symptoms and or just prevalence data. So take note of these signs, which, as I said, which are data gotten by the physicians after examining the patients. These signs are more reliable than symptoms because the symptoms are data gotten from the patients, their feelings, their observations. The second note is that diagnosis based on pattern recognition supported by prevalence is more reliable than just based on prevalence alone. Examples of diagnostic statements with quantification of probability percentage. Patient 1, primary clinical diagnosis, right breast mass, malignant, 99%. Secondary diagnosis, right breast mass, non-malignant, 1%. For another patient, it could be different. Okay, primary clinical diagnosis, right breast mass, malignant, 80%. Secondary clinical diagnosis, right breast mass, non-malignant, 20%. After the clinical diagnostic processes and formulation of the clinical diagnosis, the physician gives advice to the patient, meaning he gives and explains the findings, the diagnosis, and entertains and answers questions from the patient. The clinical diagnostic process in the patient management process ends at this box, at this advice box. So we stop here for the moment because this will be part of the lecture for today only. Okay. So let me give you the takeaway in this pep talk that are related to patient empowerment. At this point of the pep talk, understand the patient management process framework in terms of what the physicians are doing and should be doing in the goal setting and in the clinical diagnostic processes. Be ready to ask questions based on the requirements of the processes, particularly when the physician is not using the processes or is not clear and full in explanation. Participate actively and fully in the problem solving and decision making of your health concerns with your physicians in coming out with a clinical diagnosis. Master the clinical diagnostic processes as they may help you in some way in doing self-diagnosis of your symptoms in the absence of a healthcare professionals. This is another way of gaining greater control in your health concerns and issues. So this ends my pep talk for today, patient management process, clinical diagnostic process. I hope I have empowered you to have a better understanding of the goals and clinical diagnostic process in the patient management process. As a reminder, before we go to the picture taking, take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate as shown below. Okay, so I have placed the link in the chat box. Okay, and the link is also seen in the Facebook. So let's now have a group picture taking before we start the QA and interactions. Please turn on your video now. Okay. Gallery view. 1, 2, 3. Let's see. Let's have a page. I guess we have page 2. Page 2. Ready? 1, 2, 1, 2, 1, 2, 3. Pang page 3. Wala na, wala ng page 3.